Cholesterol obviously is different kinds of cholesterol, right? You have the bad, the good cholesterol, the not so good cholesterol. So when you go to your doctor and you get a cholesterol panel done, the lipid panel, it shows total cholesterol, which is a combination of your good, bad, and percentage of the triglycerides. So total cholesterol truly doesn't mean a whole lot when it comes to managing cholesterol and your risk. The LDL, which is the low density lipoprotein, is the bad cholesterol. And that is the main stroke and cardiac risk indicator. The HDL is your good cholesterol. The higher your HDL, the better it is. But still, back in the day, we had this conception that as long as your good cholesterol is really good, if your bad cholesterol is bad, well, it's okay, we could still work on it. But enough data has shown that, LDL is predominantly the sole cardiac risk indicator and stroke indicator, so we really want to target that. And then you also see a number called triglycerides. What are triglycerides? These are fat molecules directly from what you eat. The body makes it as well. The liver makes some triglycerides, but predominantly it's from the food that you eat. High triglycerides can cause pancreatic inflammation, can raise other cholesterol as well, and can still cause cardiovascular complications, unlike what we used to think back in the day. So triglycerides have become very important as well to control. There are certain genetic disorders that cause a significantly elevated LDL, and we call that familial hyperlipidemia. These are genetic causes where there's genetic mutations that increase these certain proteins, which are called apolipoproteins, which combined with the LDL go and stick to the inside of the arteries and increase blockages. So when we start treating and talking about cholesterol, and when do we start treating, when do we start using statins? The first thing to do is to assess your risk, your cardiac risk. What is your family history? What is your personal history? Diabetics, hypertensives, those who have already had a cardiovascular event, those who have had a stroke, they're all at much higher risk. Smokers, heavy alcohol use. All of these risk factors we take into account to assess your 10-year cardiac risk for an event. If you have a much higher risk than the general population, how do we bring it down? There's nothing that beats lifestyle management. So that's the first thing to remember, is that no matter what, no medication, you've got to change your lifestyle. You've got to change the way you eat, the way you exercise, so you can bring down these numbers. But if you have high family history and genetic risk based on these labs that we can do, and nowadays we just don't do just lipid panel, there is more and more data where we're trying to check on apolipoproteins, and all these different molecules and different sizes of the bad cholesterol also determines what your risk is. After all of that, then we decide what your 10-year risk is. If your risk is high, apart from lifestyle management, and if there is high genetic risk, the best way and the only way to bring these numbers down and lower your risk is statins. So I always tell patients that statins is not just for bringing the number down. Where statins have shown to be the most efficient and beneficial is that they change or regress the plaque that is built in the arteries, and they change how that plaque ruptures. A simple analogy is, imagine that you have a wall and you put paint over it, layers of paint over and over as it dries. You don't always check, are all the spots dry? So same thing with cholesterol. As it builds up, there are some spots that are soft, there are some spots that are hard. As it builds up, wherever it is weak or soft, chips off. There's no rhyme or reason for it to chip off. But the natural tendency of the body to react to that plaque rupture is to form a clot. That's when you have acute events. And there's enough data that shows statins prevent that chipping, which means essentially they stabilize the plaque and hence change the cardiac and stroke risk outcome, improve it significantly by almost 60-70%. And that's where the majority of the benefit of a statin is. Our goal is to be proactive and do primary prevention and not reactive and secondary prevention. And hence we talk a lot about statins only because of your 10-year cardiovascular risk. Statins, yes, they come with side effects like all medications do. Most common side effect for statin is muscle pain. Sometimes it can be as bad as muscle inflammation and myositis, where you're breaking down muscle, but this is reversible. The minute you stop the statin, it's resolved. It's not a long-standing effect. Statins are all metabolized like most medications in the liver, so we always worry and monitor liver enzymes. As long as you are going for regular checkups and having your liver enzymes monitored, it should be fine to take statins. There's not been data to show which statin causes the worst side effects. People tolerate and they react differently to all the multiple statins that are out there. The most common statins we use right now these days based on data is atorvastatin, which is Lipitor, and Crestor, which is rosuvastatin, because they're the strongest and most potent statins out there, which have been shown to have the biggest benefit on plaque stabilization and plaque rupture. There's been data also done at Cleveland Clinic where they've actually put in small ultrasound probes into the arteries and checked later and followed through for those who are moderate to high dose statins. And they've actually seen that when it brings down the LDL, which is your bad cholesterol, down to 70 or less, that there is in fact regression of the plaque. So there is less plaque built, but also regression of the plaque that's already there, which improves your cardiac outcome. The other common side effects with statins is, brain fog and memory loss. A lot of people are worried about, memory loss. So back in 2012, there was an FDA sort of warning about possible memory impairment on statins. Following that, there was much research done, and there was a paper that was published around in the 2020-2021 where it tried to look at the statins and the impact of that in a large trial. It was actually a trial done for aspirin, but then when they looked at all those people on aspirin with cardiac risk factors who are on statins, despite barring age, they found that there was actually no correlation at all between memory loss or progressive memory loss and statin use. They found that the memory loss was just the same as in the general population. If you do notice, if you're on statins, if you do notice memory changes or fogginess, definitely you do talk to your physician. Sometimes lowering the dose or changing to a different statin might help. Although there's no data yet that we have that shows which statin is better and which statin causes less memory impairment versus not. But there is some belief or thought process that older statins, and some statins like simvastatin has an increased fogginess than the current newer statin. I would always tell my patients, when you look at statins, don't run away from it. Have an open discussion with your physician who needs to explain to you, hey, this is your 10-year risk, of having a cardiac event. What is the risk-benefit ratio? Is the benefit so much higher than the risk of the medication? And how can we make sure that your side effects is less? Do we use a very low dose? Can we use a moderate dose? Those who already have had cardiac events and who have had strokes have more benefit when they use high-dose statins based on all the data that's available. Again, remember, I talked about plaque regression and reducing your recurrence of stroke again. So that's the whole, intent of using statins. I think having an open discussion regarding the statins and not being scared of it. Most of the side effects, again, are reversible the minute you stop it. But the point of statin is primary prevention, and in some cases, secondary prevention to lower your cardiac risk and to lower your risk of stroke as well.